Diabetes mellitus is a chronic, progressive, and multifaceted illness resulting in significant physical and psychological detriment to patients. As of 2022, 550 million people are estimated to be living with diabetes worldwide, out of which 90% have type 2 diabetes. This number expected to reach 750 million by 2050. Over the years, significant progress has been made in identifying the risk factors for developing type 2 diabetes, understanding its pathophysiology, and uncovering various metabolic pathways implicated in the disease process. This has culminated in the implementation of robust prevention programs and the development of effective pharmacological agents, which have had a favorable impact on the management of type 2 diabetes in recent times. Despite these advances, the incidence and prevalence of type 2 diabetes continue to rise. Continuing research in improving efficacy, potency, delivery, and reducing the adverse effect profile of currently available formulations is required to keep pace with this growing health challenge. Moreover, new metabolic pathways need to be targeted to produce novel pharmacotherapy to restore glucose homeostasis and address metabolic sequelae in patients with type 2 diabetes. Hello everyone, welcome back to my channel. Today, we will discuss the pathophysiology of type 2 diabetes and review how the emerging anti-diabetic agents target the metabolic pathways involved. This paper is published by Dr. Najib Shah, Hull University Teaching Hospitals NHS Trust, UK. We also discuss some of the limiting factors to developing new medication and the introduction of unique methods, including facilitating drug delivery to bypass some of these obstacles. Management of type 2 diabetes requires a patient-centered approach in bringing about lifestyle changes and optimizing glycemic control using the available pharmacological options to preserve the quality of life and minimize complications. The Kumamoto and UK prospective diabetes study confirmed that intensive glycemic control in patients with newly diagnosed type 2 diabetes significantly decreased rates of microvascular complications. Therefore, early and adequate treatment is of paramount importance. Type 2 diabetes is a progressive condition, and to prevent long-term complications, improving and sustaining glycemic control is vital. Timely treatment escalation can help achieve this. However, this is often delayed, and people remain with suboptimal glycemic control for several years. Comorbid state, insulin resistance, and beta cell dysfunction render many available treatments either inadequate or contraindicated. An intricate scenario is further complicated when treatment choices have to be informed to avoid hypoglycemia and weight gain. Due to the changing landscape of type 2 diabetes, new options for treatment are becoming more readily available. These new options are highly tolerable and powerful as they can cause fast results. When it comes to the treatment of drug-resistant BMI, one of the key constraints commonly encountered is that they are only effective individually and cannot be combined. There are many types of medications that can help patients with type 2 diabetes, the most important ones being insulin and metformin. Many have limited side effects, making them ideal for those with non-relapsing type 2 diabetes and a significant multi-organ comorbid state. Let's discuss the pathophysiology of hyperglycemia in type 2 diabetes, followed by recently included therapeutic agents and novel medication under development for the treatment of type 2 diabetes. Pathophysiology of hyperglycemia in type 2 diabetes. In type 1 diabetes, hyperglycemia caused by autoimmune destruction of B cells. In contrast, type 2 diabetes results from beta cell dysfunction and insulin resistance. There is high insulin demand from the peripheral tissues due to insulin resistance, resulting in B cell expansion and hyperinsulinemia. As a result of this compensatory response from the B cells, in the presence of a hyperglycemic, there is a steady loss of B cell mass thought to occur from accentuated apoptosis. The development of type 2 diabetes is a continuum from a state of impaired glucose tolerance, where patients exhibit a very high level of insulin resistance and have lost an estimated 80% of their beta cell function, to type 2 diabetes. To explain the pathophysiologic defects in type 2 diabetes, 8 key collaborators have been described. Pancreatic B cells decreases insulin secretion. Pancreatic cells increase glucagon secretion. The liver increases hepatic glucose output. The muscle decreases glucose uptake, and adipose tissue increases lipolysis. The kidney increases glucose reabsorption. Gut decreases incretin effect, and finally, the brain improves appetite regulation, which were collectively called the ominous octet. In diabetes, the complex system required to maintain euglycemia independent of glucose load and clearance fails, and the fascinating interplay between insulin resistance, impaired insulin secretion, and loss of B-cell mass has long been targeted with therapeutic agents to treat this condition. Clinical trial results of combined peptide injectables. By increasing B-cell insulin secretion, delaying gastric emptying, and reducing glucagon secretion, glucagon-like peptide 1 analogs successfully target and suppress postprandial hyperglycemia in type 2 diabetes. On the contrary, basal insulin therapy targets fasting hyperglycemia, and theoretically, when combined, their complementary action should result in significant improvement in glycemic control. This materialized with the introduction of idaglera, 50U insulin digludec, and 1.8 mg liraglutide, and iglar-lixi, 100U insulin glargine, and 50 mg lixisenatide in a titratable fixed ratio combination. The FDA approved both combination injections for clinical use in 2016. Results from the dual action of liraglutide and insulin digludec in type 2 diabetes clinical development program demonstrated the efficacy and safety of idaglera in 1393 adults with type 2 diabetes who had inadequate glycemic control on liraglutide or basal insulin alone. Switching to idaglera resulted in a mean reduction in hemoglobin A1c up to 1.94%. As evidenced by several studies, both idaglera and iglar-lixi achieved more significant HbA1c reductions without increasing the risk of hypoglycemia in patients with type 2 diabetes compared to individual insulin or GLP-1 analogs. All these attributes make these injections suited for the management of type 2 diabetes and can be utilized at the treatment intensification stage of the management algorithm. Results of glucose-dependent insulinotropic polypeptide and glucagon-like peptide 1 receptor agonists. GIP is an incretin hormone like the much talked about glucagon-like peptide 1. Together, they are responsible for enhancing glucose-dependent insulin secretion from the pancreatic B cells termed the incretin effect. Under normal physiological circumstances, the incretin effect is mainly driven by GIP. Developed by Eli Lilly, tirzepatide, LY3298176, is a glucose-dependent insulinotropic polypeptide and glucagon-like peptide 1 receptor dual agonist, which has achieved superior HbA1c and weight reductions compared to injectable semaglutide as an add-on to metformin in adults with type 2 diabetes. In the phase 3, in this 40-week, multi-center, randomized, parallel, open-label trial, participants taking weekly tirzepatide 15 mg, the highest dose achieved an HbA1c reduction of 2.46% and weight loss of 13.1% compared to weekly semaglutide 1 mg. As a result, tirzepatide engages GIPR more than the GLP-1R, and the unique signaling properties at the GLP-1R may form the basis of its profound efficacy. GLP-1R or GIPR dual agonists have shown significantly better efficacy in terms of glycemic control and weight loss compared to GLP-1R agonists, with satisfactory tolerability, and so will be a welcome addition to the therapeutic options in type 2 diabetes. The next class of drugs are sodium glucose cotransporter 1 and 2 inhibitors. Dual sodium glucose cotransporters regulate sodium and glucose transport across cell membranes. 6 sodium glucose cotransporter isoforms have been identified in human beings. However, only 1 and 2 inhibition has translated into pharmacotherapy in type 2 diabetes so far. Sodium glucose cotransporter 1 is a high affinity but low capacity transporter, which mediates the absorption of glucose in the small intestine and accounts for the reabsorption of approximately 3% of the filtered glucose from the S3 segment of the proximal convoluted tubule in the nephrons. In contrast, sodium glucose cotransporters 2 is a low affinity but high capacity transporter which is responsible for greater than 90% of glucose reabsorption from the S1 and S2 segments of the proximal convoluted tubule in the nephrons. Targeting the inhibition of sodium glucose cotransporters 2 could lead to glucosuria and improved glycemia. In 2012, dapagliflozin was approved by the European Medicines Agency for clinical use. The following year, canagliflozin was approved by the Food and Drug Administration for clinical use, and thereafter several agents have been approved and marketed around the world. Recent pharmacological research suggested that combined sodium glucose cotransporters 1 and 2 inhibition such as sotagliflozin resulted in significant postprandial glucose reduction, the elevation of endogenous glucagon like peptide 1 and urinary glucose excretion. Sotagliflozin has a 20-fold higher selectivity for sodium glucose cotransporters 2 than 1. From phase 2 and 3 clinical trials, sotagliflozin has demonstrated improved glycemic control, reduced postprandial glucose, reduced insulin requirements, appetite suppression, and weight loss in patients with type 2 diabetes. In the SOLOIST WHF clinical trial, sotagliflozin therapy resulted in a significantly lower total number of deaths from cardiovascular causes, hospitalizations, and urgent visits for heart failure compared to placebo in patients with type 2 diabetes. Moreover, in the SCORD clinical trial, treatment with sotagliflozin resulted in a similar effect in patients with type 2 diabetes and chronic kidney disease with or without albuminuria. Another dual sodium glucose cotransporter 1 and 2 inhibitor, licagliflozin, has been shown to exert a favorable metabolic effect leading to weight loss, reduced PPG excursion, and elevation of total glucose like peptides 1 level in patients with obesity and type 2 diabetes. Based on the overwhelmingly encouraging results from sotagliflozin, it seems that approval for use in type 2 diabetes is not far away. As time goes on, other agents from the novel class may emerge as clinically beneficial for the treatment of type 2 diabetes in the future. Let's discuss peroxisome proliferator activated receptor alpha, gamma, and delta pan agonists. Peroxisome proliferator activated receptors are ligand-activated transcription factors of nuclear hormone receptors. Their subtypes include peroxisome proliferator activated receptor alpha present in the liver, muscle, and heart, peroxisome proliferator activated receptor gamma present in adipose tissue and vascular endothelial cells, and peroxisome proliferator activated receptor delta widespread whole body distribution, which plays an integral part in energy metabolism, where peroxisome proliferator activated receptor delta regulates energy expenditure, while peroxisome proliferator activated receptor gamma mediates its storage. Thiazolidinediones, also called TZDs, are anti-diabetic agents in clinical use since 1997. They are peroxisome proliferator activated receptor gamma agonists, which enhance insulin sensitivity by increasing adiponectin and GLUT4 expression and oppose the effect of tumor necrosis factor alpha in adipocytes. These actions result in reduced hepatic gluconeogenesis and increased insulin-dependent glucose uptake in muscle and fat. Chiglitazar, a novel peroxisome proliferator activated receptor alpha, gamma, and delta pan agonist, has been investigated in phase 3 multi-center, randomized, double-blind, and placebo-controlled trials, as well as sitagliptin-controlled trials in patients with type 2 diabetes with insufficient glycemic control despite diet and exercise. Compared to the placebo at 24 weeks, both doses of chiglitazar were superior to the placebo in hemoglobin A1c reduction, and the effects were sustained for 52 weeks. The mean change in hemoglobin A1c was higher with chiglitazar 32 mg compared to baseline and placebo. Although hypoglycemia, weight gain, and edema were relatively more common with chiglitazar, the overall adverse events were comparable across all groups with no major safety concerns. GLICLAZIDE plus METFO-RMIN, a novel oral anti-diabetic drug, imeglimin, has been developed and is a member of the glimins class of agents and is being studied in many landmark clinical trials. In patients with type 2 diabetes, imeglimin has shown sustained improvement in hyperglycemia without disabling hypoglycemia and was not associated with a concerning side effect profile. Its unique mechanism of action not only increases glucose-dependent insulin secretion, but also reduces insulin resistance. By inhibiting the process of oxidative phosphorylation, mitochondrial disorders can be prevented or lessened. This in turn gives off positive effects such as a good metabolism and lower chances of developing certain diseases. Imeglimin counteracts a variety of metabolic disruptions at play in type 2 diabetes. It accelerates the phosphorylation of ACT protein kinase B, leading to enhanced insulin signaling, and has also been linked to the induction of insulin sensitivity in the B cells. In addition to this, imeglimin reduces hepatic gluconeogenesis, is protective against B cell death, increases the B cell mass, and improves glucose-induced insulin secretion from islets of Langerhans cells in the pancreas. These findings suggest that imeglimin is potentially cardioprotective in addition to its anti-diabetic properties, and thus once approved for commercial use, will be a useful inclusion to the arsenal against type 2 diabetes. Based on its potent anti-diabetic effect as monotherapy and as an adjunctive treatment, the lack of major adverse effects, and potential cardioprotection, imeglimin is poised to occupy a crucial role in the future of type 2 diabetes pharmacotherapy. Next one is therapies targeting the glucagon receptor such as GLP-1R and glucagon receptor dual agonists. At least 90% of patients with type 2 diabetes are overweight, and this is the major risk factor for the disease's development. GLP-1R agonists improve glycemic control and reduce weight in patients with type 2 diabetes. They are an effective pharmacological treatment because of the many health benefits they offer, such as preventing cardiovascular complications. Glucagon is a peptide hormone produced by the cells of the islets of Langerhans. Acting via the glucagon receptor, it increases glucose concentration in the bloodstream via gluconeogenesis and glycogenolysis, increases lipolysis, improves energy expenditure, and can activate the GLP-1R, leading to a glucose-lowering effect. In diet-induced obese mice, Parker demonstrated that GLP-1 and GCGR dual agonism lead to superior weight loss compared to GLP-1R agonists alone, while the lipid-lowering and anti-hyperglycemic activity of both classes were comparable. Chronic administration of GLP-1 or GCGR dual agonists leads to a more pronounced improvement in plasma metabolic parameters such as insulin, leptin, and adiponectin compared to GLP-1R agonists alone. Oxyntomodulin, JNJ 64,565,111, and MEDI382 are examples of some agents being developed in this emerging class, with some encouraging results being reported with MEDI382 recently. Let's see the glucagon receptor antagonist. Glucagon and insulin exhibit opposite metabolic effects. Glucagon regulates glucose homeostasis through hepatic glucose production via gluconeogenesis and glycogenolysis. Glucagon receptor antagonists are a novel class of anti-hyperglycemic agents designed to target hyperglycemia in diabetes by blocking glucagon action through its receptor. Glucagon receptors differ chemically and on this basis can be classified into small molecules, monoclonal antibodies, and antisense oligonucleotide agents. A variety of glucagon receptors studied in clinical trials have been shown to improve glycemic control in terms of hemoglobin A1C, but clinically significant adverse effects have precluded their use as therapeutic options in clinical practice. Weight gain, elevated hepatic enzymes, increase in low-density lipoprotein C levels, and liver fat content, rise in systolic blood pressure, and a cell hyperplasia are some of the concerns reported with glucagon receptors use. Efforts are underway to minimize the side effects of glucagon receptors, and many agents are currently being developed from this class. GLP-1R or GCGR or GIPR triple agonists. Following Roux-en-Y gastric bypass or RYGBP surgery, it was noted that the endogenous GLP-1, GIP, and glucagon or incretin secretion was increased. It was theorized that these incretins' synergistic metabolic action could lead to weight reduction. HM15211, currently in phase 1 clinical trials, is a weekly SCGLP-1R or GCGR or GIPR triagonist peptide being developed by Hanmi Pharma to treat obesity and type 2 diabetes. It is a modified human glucagon molecule formed by conjugating to human immunoglobulin GFC fragment through PEG linkage. To assess the efficacy in the treatment of obesity, HM15211 was compared with liraglutide in diet-induced obese mice, where early results have shown a threefold reduction in weight and increased energy expenditure with HM15211 compared to liraglutide. Moreover, in methionine choline deficient or MCD mice, HM15211 administration resulted in a reduction in hepatic TGs and thiobarbituric acid reactive substances or TBARS. A concurrent fall in serum alanine aminotransferase or ALT and bilirubin was also observed. HM15211 resulted in increased intracellular CAMP through GLP-1R, GCGR, and GIPR. Its robust glucagon activity caused weight loss and improved lipid profiles by accelerated lipid oxidation. GLP-1R and GIP serve to neutralize glucagon-induced hyperglycemia. By affecting weight loss and improving lipid profiles, this class could provide an attractive therapeutic option for treating obesity and type 2 diabetes. NN9423 by Novo Nordisk and GGG triagonist by Eli Lilly are examples of some other GLP-1R or GCGR or GIPR triple agonists which are currently under development. G-protein coupled receptor ligands. A variety of mediators acting through G-protein coupled receptors can enhance and inhibit glucose-induced insulin secretion, or GSIS. Let's discuss the first one, called GPR119 agonist. GPR119 is a class of orphan GPCR found in the pancreas and the gastrointestinal tract, and can regulate insulin and incretin release. Its activation leads to the intracellular accumulation of CAMP, resulting in GSIS from the pancreatic B cells and incretin release from the gut. Due to the dual effect of GSIS and incretin release coupled with a low risk of hypoglycemia, these agents have drawn considerable interest as a therapeutic entity in the management of type 2 diabetes. Unfortunately, no synthetic GPR119 ligand has been approved for treatment, nor has any passed beyond phase 2 clinical studies. DS85O is a GPR119 agonist being developed by Daiichi Sankyo Company and is currently in phase 2 clinical trials. Next one is free fatty acid receptor. Several agents have been identified to have anti-hyperglycemic action by stimulating or blocking the free fatty acid receptor, or FFAR. Among the FFARs, FFAR1 or GPR40, FFAR2 or GPR43, FFAR3 or GPR41, and FFAR4 or GPR120 have emerged as anti-diabetic targets. Long-chain free fatty acids, or FFAs, activate FFAR1 and FFAR4, and agonists of these two receptors have been proven to enhance insulin and incretin release. Short-chain FFA activates FFAR2 and FFAR3, and as opposed to FFAR1 and 4, antagonism of these receptors has shown anti-diabetic potential. Mice studies have demonstrated that FFAR2 and FFAR3 antagonists can enhance insulin secretion and glucose tolerance. Agents targeting the FFAR are still in the early stages of development, and it remains to be seen whether an effective and safe drug can be delivered and inducted into clinical practice from this class in the future. G-protein coupled receptor 5 or TGR5 agonists, also known as GPBAR1 and GPR131, is a bile acid specific receptor found in the gastrointestinal tract, pancreas, liver, gallbladder, and adipose tissue. A lot of research has gone into establishing a link between bile acids and glucose metabolism, with numerous studies showing bile acid-mediated TGR5 activation resulting in impactful glucose metabolic sequelae including GLP-1, insulin, and glucagon release. The ability to stimulate GLP-1 secretion has attracted considerable interest. However, this effect may be limited as TGR5 receptors are predominantly present in L cells' basolateral membrane, leading to insufficient luminal activation required to produce the desired metabolic impact. Studies in rodents suggest an important role for TGR5 in GLP-1 secretion, and therefore it is an important target for the development of pharmacotherapy directed against metabolic diseases, including type 2 diabetes. However, data from animal studies showed significant safety concerns with TGR5 agonists treatment, for most of which were gallbladder dilation, pancreatitis, and hepatic necrosis. Human studies have reported no beneficial effects on GLP-1 secretion or plasma glucose levels, and as such, currently a viable pharmacological option using this concept is not on the horizon. SB 756050, originated by GlaxoSmithKline, was a TGR5 agonist studied for the treatment of type 2 diabetes. 51 participants were randomized to receive either a placebo or one of 4 doses of SB 756050 for 6 days. A single 100 mg dose of sitagliptin was co-administered on day 6 to all participants. It was well tolerated, however, exhibited variable pharmacodynamic effects, with the rise in glucose at the 2 lowest doses and no fall in glucose at the 2 highest doses. The glucose effects of SB 756050 and sitagliptin were comparable to those of sitagliptin alone. Studies on SB 756050 were eventually discontinued in phase 2 clinical trials. And finally, the melatonin receptor. Peripheral and central insulin resistance, glucose intolerance, and reduced expression of the GLUT4 gene have been observed in pinealectomized animals, which improved with melatonin administration. Furthermore, a reduction in melatonin formation has been reported in animal models with type 2 diabetes. MT1 and MT2 are isoforms of melatonin receptors expressed on hepatocytes and pancreatic cells, forming part of the glucose regulation pathway. Various studies demonstrate that melatonin-mediated activation of these receptors improves insulin sensitivity and suppresses gluconeogenesis. In the past, MT1 and MT2 knockout mice have been shown to have systemic insulin resistance, and reduced insulin sensitivity, with the latter exhibiting increased insulin release. In contrast, pyrimetine, a novel melatonin receptor agonist, has been shown to exert a protective effect on insulin sensitivity and lipid metabolism in sleep-deprived rats. Enzymes, hormones, and receptors as therapeutic targets for diabetes treatment. The first one is the protein tyrosine phosphatase 1b inhibitor. Protein tyrosine phosphatases, also known as PTPs, lead to the inactivation of the insulin receptor via dephosphorylation. PTP1B downregulates insulin and leptin pathway and therefore has been seen as a therapeutic target for the treatment of diabetes and obesity. PTP1B deficient mice were observed to be sensitive to insulin and had a degree of resistance to weight gain. Selective, reversible, and high-affinity PTP1B inhibitors have been tested in animal models, but being highly charged molecules, they could not be developed into medicinal products. KQ791, developed by Kinetic Bioscience, has been studied in a phase 1 interventional randomized placebo-controlled trial for the treatment of type 2 diabetes. The study consisted of 81 participants, which were divided into 4 groups based on the regimen of KQ791 they received over a period of 4 weeks. The primary outcome measure was the difference in change in fasting blood glucose between KQ791 and placebo from baseline to day 29. The results suggested superior improvement in fasting blood glucose in group and group 2 compared to group 3 and 4 placebos. No serious adverse event was recorded with any intervention group. Next one is the human pro-islet peptide. Diabetes is a chronic illness and is characterized by a lack of functioning pancreatic B cells at advanced stages. Increasing B cell numbers to alleviate diabetes is the logical answer. However, this is cumbersome to deliver in clinical practice. Transplantation of donor islets has been explored but has been limited by insufficient donors. Where successful islet transplantation has been achieved, patients have been plagued with post-transplantation sequelae, including rejection and adverse effects of immunosuppressive therapies. The human pro-islet peptide, a HIP, is a 14-amino acid, biologically active fragment encoded by the human REG3A gene with the ability to increase B cell mass, thereby improving glycemic control. In streptozotocin-induced diabetic mice, John has demonstrated that HIP promotes the differentiation of human fetus-derived pancreatic progenitor cells, or HFPPCs, into insulin-secreting cells, leading to a significant reduction in hyperglycemia. Phase 1 clinical trials with BTI-410, or the first agent in the class of HIPs, established good safety and tolerability in patients with type 2 diabetes, with promising results. Next one is fibroblast growth factor 21 analogs. Fibroblast growth factors, or FGFs, are signaling molecules responsible for wide-ranging functions from development and regeneration to maintaining metabolic homeostasis. FGF21 is an atypical member of this family, produced from the liver. It is involved in regulating glucose and lipid metabolism. Elevated FGF21 levels in obese animals have been observed to reduce hyperglycemia, body weight, and lipid concentration. Recombinant FGF21 also demonstrates a similar effect in various diabetic animal models. Pegbelfermin is a recombinant PE-gylated FGF21 that is well tolerated and significantly reduces fat fraction in patients with non-alcoholic steatohepatitis. A randomized, double-blind, placebo-controlled trial was carried out in which patients with type 2 diabetes for a duration of 12 weeks. At 12 weeks, pegbelfermin therapy did not impact HbA1c concentrations compared to placebo. However, significant differences versus placebo were noted for a reduction in FPG and an increase in whole body insulin sensitivity. In addition, significant improvements were observed in high-density lipoproteins and TG for the 20 mg daily regime versus the placebo. Injection site bruising and reaction together with diarrhea were among the commonly reported adverse events. Based on these results, pegbelfermin warrants further investigation in the evaluation of its efficacy in obesity-induced metabolic conditions. Adenosine monophosphate analogs. Adenosine monophosphate, or AMP, predominantly activates adenosine monophosphate activated protein kinase, or AMPK. Once activated, AMPK exhibits an insulin sensitizing effect, reducing hepatic gluconeogenesis and lipogenesis via negative regulation of specific genes, while promoting peripheral glucose uptake and lipid oxidation in skeletal muscles. Low levels of AMPK have been noted in patients with diabetes, and its activation is one of the cellular mechanisms through which metformin exerts its anti-diabetic effect. Novel agents which can activate AMPK or serve as AMP analogs have been explored as potential therapeutic modalities in type 2 diabetes. First in class, AMPK activator O304 is a pan-AMPK activator studied in a proof of concept phase 2A single-center randomized parallel group double-blinded placebo-controlled trial in patients with type 2 diabetes on metformin. 65 patients with type 2 diabetes were studied for 28 days and resulted in a mean absolute reduction in FPG at day 28 compared with the placebo group. In addition to these findings, O304 resulted in an increase in microvascular perfusion as well. These beneficial effects may allow it to play an important role in treating patients with type 2 diabetes complicated with cardiovascular disease. Next one is glucokinase activators. Glucokinase or GK, also known as hexokinase type IV, is part of the hexokinase enzyme family, mainly expressed in the pancreas, liver, brain, and gastrointestinal tract. It facilitates the phosphorylation of glucose to glucose 6-phosphate. It regulates glucose-induced insulin secretion, hepatic glucose uptake, and glycogenesis, thus regulating whole-body glucose homeostasis. Based on the characteristics mentioned above, agents activating glucokinase have a therapeutic potential in type 2 diabetes. Numerous GK activators developed thus far have shown significant glucose-lowering capabilities. However, a concomitant increase in plasma triglycerides and loss of efficacy with continued administration meant that they could not be used as therapeutic entities. TMG 123, a novel GK activator, has been shown to overcome these limitations and, in animal studies, has demonstrated glucose-lowering effects without affecting hepatic and plasma triglyceride. As the plasma insulin levels were not increased, it is likely that TMG 123 mainly acts in the liver. Although it is a viable candidate for development as a new treatment for type 2 diabetes, its safety needs to be evaluated further as Kobayashi and colleagues have shown that TMG 123 causes long-lasting hypoglycemia and irreversibly impairs spermatogenesis in rats. TTP 399 is another glucokinase activator being investigated as a potential therapy in both type 1 and type 2 diabetes. Final molecule from this category is 11-beta-hydroxysteroid dehydrogenase 1 or 11-beta-HSD1 inhibitors. 11-beta-HSD1 is a reductive nicotinamide adenine dinucleotide phosphate or NADPH-dependent enzyme predominantly expressed in the liver, adipose tissue, gonads, and brain, and is responsible for the formation of cortisol from its inactive metabolites and cortisone. Cortisol regulates energy homeostasis in the liver and adipose tissue and has been well characterized to impair peripheral glucose uptake and increase hepatic insulin resistance. Stimson and colleagues have shown that the whole body 11-beta-HSD1 activity is increased in obese men with type 2 diabetes, making the inhibition of 11-beta-HSD1 a target for treating type 2 diabetes, especially in those with high fasting blood glucose, as shown by Shukla and colleagues. Several compounds have entered clinical trials and have demonstrated modest improvement in glycemic control, together with favorable changes in some metabolic syndrome parameters. 11-beta-HSD1 inhibition will reduce the levels of circulating cortisol and, due to a lack of negative feedback, will increase levels of adrenocorticotropic hormone or ACTH. This can result in adrenal hypertrophy, accumulation of adrenal androgen precursors, and depression. Y135585, a selective 11-beta-HSD1 inhibitor, was evaluated in an open-label administration of Y135585 200 mg as a single dose in 9 healthy volunteers, and a multiple-dose study with randomized, double-blind administration of Y135585 or placebo once daily in 72 participants with type 2 diabetes over a period of 2 weeks. It was found to be safe and was well tolerated. However, the adrenocorticotropic hormone was noted to be slightly raised, but within the normal range. Serum cortisol levels remained unchanged, and increased total urinary corticoid excretion was noted. While these are positive results, their safety profile and therapeutic potency need to be investigated in further trials over a longer period. Final topic is insulin. For the management of type 2 diabetes, insulin therapy is initiated generally as a last resort when patients fail to achieve their glycemic targets with 2 or more oral hypoglycemic agents, or OHAS, or with non-insulin injectable medication. Various insulin preparations are now available in clinical practice, ranging from rapid to long-acting preparations. As with other areas in the management of type 2 diabetes, insulin therapy has also been a focus of research, and work has been done to devise insulin preparations with alternate delivery methods. Compounds have been developed with a longer duration of action to reduce the frequency of injections. Very first molecule is oral insulin. Following its endogenous release from the B cells in the pancreas, insulin is transferred to the liver, where it undergoes degradation from the hepatic first-pass metabolism, resulting in a concentration gradient between the hepatic portal and peripheral systemic circulation. As parenteral insulin preparations are directly delivered to the peripheral circulation, they fail to achieve the described concentration gradient, resulting in the reversal of normal physiology. Therefore, when injected, insulin reaches the liver at a lower concentration, and insulin-treated diabetic patients tend to develop weight gain and hypoglycemia as a manifestation of peripheral hyperinsulinemia. Oral insulin, on the contrary, mimics normal physiology, leading to better glycemic regulation. Once absorbed from the gut, insulin is delivered to the liver via the portal circulation, building a high portosystemic gradient. Reduced levels of systemic insulin alleviate hypoglycemia and issues with weight gain. As a peptide hormone, insulin is susceptible to degradation from acid hydrolysis in the stomach and proteolytic cleavage in the intestine. These factors have made the production of viable oral insulin preparation challenging. There is an emphasis on protecting and enhancing peptide drug absorption. To achieve this, researchers have employed innovative measures such as mucoadhesive polymers, micronization, absorption enhancers, protease inhibitors, and particulate carrier systems. A recent randomized, placebo-controlled, phase 2b trial with the novel oral human insulin, ORMD801, has shown promising results in subjects with poorly controlled type 2 diabetes. ORMD801 achieved a significant reduction in HbA1c without an increase in the frequency of hypoglycemia or weight. Oral devices comprising mucoadhesive patches and enterically coated capsules are another insulin delivery technique on the horizon. Tupti developed a mucoadhesive patch of carbapol 934, pectin, and sodium carboxylethyl cellulose in a 1:1:2 ratio. The results are an encouraging step towards the development of another non-invasive anti-diabetic therapeutic option in the form of sustained-release mucoadhesive patches promoting oral peptide delivery to improve patient compliance and drug adherence. Transdermal insulin. The use of the transdermal route for drug delivery has been around for a long time. In terms of insulin delivery, the transdermal route alleviates the discomfort and inconvenience of regular subcutaneous injections. This is especially true for patients on multiple daily injections or MDIs of insulin. It bolsters compliance among patients while ensuring controlled insulin release over a while. The lack of adequate permeability of the stratum corneum is the main limiting factor with this route. Over the years, researchers have been working on methods to bypass this obstacle, leading to the discovery of various novel techniques to achieve this. One is the subcutaneous insulin patch pump system. Using novel technologies, insulin patch pump devices provide accurate and flexible insulin delivery. Omnipod is a simple, specific mall patch pump, flexible, discreet, without tubing, and cheaper, making them more attractive than continuous subcutaneous insulin infusion systems. The VG/TM device, on the other hand, can deliver basal and bolus insulin over 24H and is suitable for patients on multiple daily insulin injection regimes. The patch pump targets a large cohort within the diabetes population. However, for patients with type 2 diabetes who are on simple insulin regimes, the simple specific patch pump is an exciting prospect, as in clinical studies they have demonstrated improved glycemic control, user satisfaction, and were cost-effective compared to MDI insulin regimes. Another device is a closed-loop pump system. Over the last few years, particularly in the domain of blood glucose monitoring and insulin delivery, advances in technology have revolutionized diabetes care. The introduction of closed-loop or CL pump systems is one such technological marvel, where continuous glucose monitoring or CGM and an insulin pump function in a unified manner, achieving automation in glucose-responsive insulin delivery with the help of a computerized algorithm that adjusts basal insulin in response to data obtained from the CGM, helping to maintain glucose levels in the target range. Dual hormone CL pump systems can also deliver glucagon in a glucose-responsive manner, and therefore, the CL pump systems reduce the user burden by automatically adjusting insulin delivery based on sensed glucose continuous glucose monitor. The HCL system can make regular self-directed adjustments to the basal insulin delivery rate, which prevents large fluctuations in blood glucose, and overall. These novel insulin delivery systems have resulted in improved glycemic control and reduction in hypoglycemic events in people with type 1 diabetes. Next one is an inhaled insulin. DANS 501 from DANS Biopharm is a pulmonary insulin delivery or human insulin administered with a pocket-sized smart inhaler using vibrating mesh micropump technology developed by Erogen. Data from a phase 2 randomized, controlled study comparing DANS 501 to subcutaneous insulin Lispro in type 2 diabetes demonstrated faster onset and greater action in the first hour of administration than SC insulin Lispro, with good tolerability and without any pulmonary safety concerns. The last category is once weekly insulin. Due to the lack of compliance and acceptance in some patients, multiple daily basal insulin injections proved to hinder this venture. Novo Nordisk has developed a long-acting insulin analog, insulin icodec, which has now entered phase 3 clinical trials. In a randomized, double-blind, double-dummy, phase 2 clinical trial, Rosenstock compared the safety and efficacy of insulin icodec with once daily insulin glargine U100 in insulin-naive patients with type 2 diabetes. At 26 weeks, insulin icodec demonstrated similar glucose-lowering efficacy to once daily insulin glargine U100. There were no significant safety concerns with insulin icodec either, with observed hypoglycemia rates similar to those in the insulin glargine group. From the available evidence so far, without compromising glycemic control, insulin icodec can reduce the frequency of basal insulin injections and improve compliance, making it an exciting prospect for the future. Genome-wide association study and type 2 diabetes. A recent meta-analysis of GWAS with 16 million genetic variants in type 2 diabetes cases has led to the identification of 143 variants associated with type 2 diabetes, over 3 dozen of which were previously unknown. Following a genome-wide association meta-analysis, Desmok and Madsen identified CDKAL1 and GIPR-QPCTL loci as important determinants of beta cell glucose sensitivity. Similar studies have uncovered genes that are targets for current therapeutics. KCNJ11, GLP1R, and PPARG are gene variants identified by this method for type 2 diabetes targeted by sulfonylureas, GLP-1 analogs, and thiazolidine diane, respectively. Identification of genetic variants implicated in complex pathologies, the presence of successful drug therapies against these targets, and the development of new treatments using knowledge from GWAS have lent substantial credence to this approach. In the future, advances in this strategy can inform the development of effective and may be curative pharmacotherapy for type 2 diabetes. New agents and delivery methods in pre-existing classes of medication for the treatment of type 2 diabetes. Sodium glucose cotransporter 2 inhibitors, glucose-like peptide 1 analogs, and dipeptidyl peptidase 4 or DPP4 inhibitors are among the new classes of medication for the treatment of type 2 diabetes developed over the last 15 years. Their novel MOA, ease of administration, effective glycemic control, weight reduction capability, and cardiovascular and renal protection have had an overwhelmingly positive impact on the management of type 2 diabetes. Conclusion: since the groundbreaking work of the French physician Gilles Stern, who studied metformin for the first time in humans in the 1950s to treat diabetes, the industry has come a long way in investigating, developing, and delivering beneficial treatment modalities in type 2 diabetes. Most novel compounds produced for treatment have shown a potent anti-hyperglycemic effect. However, they need to be examined further to ensure that their use is safe and well tolerated in clinical practice. Various new therapeutic targets have been explored. However, an extension of previously known mechanisms has yielded greater success, as in the case of sotagliflozin, for example. Oral and once-weekly insulin, insulin patch pumps, and once-monthly GLP-1 analogs are exciting prospects with the potential of conferring significant clinical benefits to patients. Can the academic and pharmaceutical industries come together and uncover an agent which reverses the underlying mechanisms fueling dysglycemia and normalizes glucose homeostasis, resulting in the cure of type 2 diabetes? Perhaps the advances in monoclonal antibody and gene therapy will provide this answer in the future. Thank you so much for being so patient and have a nice day.